Welcome to the broadcast. We will begin in 2 minutes.
Hello, and thank you for joining today's webinar. We will begin in 1 minute. Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. The speakers and planning committee members have disclosed no conflicts of interest. To receive contact hours for this CNE session, participants are required to attend the webcast and complete the evaluation form, which will be emailed to the attendees approximately 1 day after the webcast. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, we will have a question and answer session. You will see on your GoToWebinar control panel that you can send a message through the questions feature. This is where you can type in any question you'd like to pose to the presenters. Be sure to hit send so the message makes it to us. To test this feature, please submit the state or country you are from. We would like to thank our speakers for sharing their expertise with us today. Our speakers are Dr. Christine Grady and Dr. Connie Ulrich. Dr. Christine Grady is a nurse bioethicist and a senior investigator and chair of the Department of Bioethics at the National Institutes of Health Clinical Center. Dr. Grady was a commissioner on the President's Commission for the Study of Bioethical Issues from 2010 to 2017. She is an elected fellow of the Hastings Center and the American Academy of Nursing, research fellow at the Kennedy Institute of Ethics, and an elected member of the National Academy of Medicine. Dr. Connie Ulrich is the Lillian S. Bruner Chair in Medical and Surgical Nursing and a professor of bioethics and nursing at the University of Pennsylvania School of Nursing with a secondary appointment in the Perelman School of Medicine, Department of Medical Ethics and Health Policy. Dr. Ulrich was trained in bioethics at the National Institutes of Health and the Department of Bioethics. Now let's go ahead and get started with today's presentation.
Thank you so much for the introductions. It is a pleasure to be here. Good evening to everyone who is online. Christine and I are very pleased and we're very honored to be here tonight to talk about our professional and ethical obligations to patients, but also those obligations to ourselves during this COVID-19 pandemic. We realize that it is stressful for all of us. So we thank you all for being online and for listening, and we certainly will welcome any thoughts that you might have regarding these particular issues. And again, just to reiterate that Christine and I have nothing to disclose. We have no conflicts of interest. We have 3 learning objectives for tonight. First, we'd like to identify and discuss the various professional and ethical challenges that nurses are facing during the COVID-19 pandemic. We'd also like to give examples of allocation frameworks during a public health crisis that you might be able to use, and then to think about and discuss our own safety and well-being during this crisis. First, we'd like to thank all of the healthcare providers who we know are doing their very best in times of extreme stress, moral distress, and certainly ethical uncertainty. We owe you a debt of gratitude. We cannot express enough how appreciative we are for all of you who are on the front lines or working in some other capacity during this pandemic. We'd also like to thank Sigma Theta Tau International for their leadership. We are so grateful to them for thinking about nurses and others who are on the front lines, and for their commitment to bringing the professional and ethical challenges forward for discussion, both within and outside of the profession. And I'd like to especially thank the CEO of Sigma Theta Tau, Elizabeth Madigan, for reaching out to me and to Christine to help think about these particular issues, and certainly Megan and Erica for helping us with all the technological blips that we had experienced. So thank you very much. There are several key questions, I think, for us to think about tonight, and we have them listed here, and let me just state what we think they are. First of all, what are our professional and ethical obligations to patients and families? And how might pandemic dynamics change the standards of care? How do we meet those standards of care, and can we even meet those standards of care? What are the challenges to meeting our obligations in caring for patients at this time? Particularly, how should nurses care for patients in the setting of scarce resources and personal risk? And how should nurses make decisions about possible limits on patient care? And these are all very difficult questions for us to ponder and to think about. I wanted to show this slide because I teach bioethics. I'm a nurse bioethicist, and I teach bioethics at the University of Pennsylvania School of Nursing. And when I first started teaching in the spring semester, that was in January. So this was my second class, and this was around January 29th of 2020. And I usually bring something in from the news for my students that is bioethics related. And this was the slide that I brought in that particular week. And it was where we began to see an emerging infectious disease whereby over 4,500 people were infected with what was called then the coronavirus, and this originated in Wuhan, China, and 106 deaths had occurred. And as you can see on the slide, there were very small numbers in other Asian countries. There were a few cases in Australia at that time. There was one case in Canada, but it was very small numbers. And I asked my class, if this were to happen in the United States, what do you think would be our obligations with regards to our patients? I never thought, in all honesty, that we would be where we are today. I never really imagined that. And when you look at this slide, what we are seeing today, and Christine and I have changed the slide possibly, I think, like more than 4 times, and thinking about the numbers because they certainly have changed every hour. And this was as of about 5 p.m. Last evening. And so looking at the numbers tonight, they certainly have changed. But as we can see, the pandemic is in every country and across every territory. We know that as of tonight, there are confirmed cases in the United States of more than 380,000 cases. There are more than 12,000 deaths in the United States. Globally, there are more than 1.4 million cases, and more than 80,000 deaths have occurred globally, with more than 100 healthcare workers who have died throughout the world, and that includes nurses, physicians, paramedics, dentists, technicians, physician assistants, pharmacists, and others. I think when we see these statistics, we are rightfully worried, and we have some fear as to what this means for us as a society, what this means for us as a global community, what this means for us from a healthcare systems perspective across the globe, and how will we continue to deliver quality care based on the standards of care to which we have been trained and to which we know? And how will we flatten the curve, to use the language of our scientific experts so that we can move forward? So we have very different practice realities today, and we are grappling with many challenging ethical issues, and we've listed a few here that we've been thinking about, and they include the following: providing needed care for very ill patients, increasingly under conditions where demand exceeds capacity, dealing with the scarcity of personal equipment that might protect us, and scarcity of staff and beds and ventilators and other resources, caring for colleagues or friends who become ill, who might need ventilation, and who might be in the ICU. Working with distressed patients, families, and staff, particularly those patients who might be at end of life and are alone. worrying about our own safety and our overall well-being. Will we transmit this to our loved ones, our family, our friends, our partners, and others? And certainly concerned about the marginalized and many, many other issues. So Christine and I think that we are in somewhat uncharted waters, both professionally and ethically. And many people in the bioethics community have started to think carefully about these issues and have developed helpful frameworks, some guidelines, and some algorithms. And we will present some of those to you. Yet I think it's fair to say that there are very few universally accepted answers for nurses and others who are on the front lines. But we will do our best to share our thoughts and our experiences with you as nurse bioethicists. And we certainly welcome your thoughts and questions on what you believe are the professional and ethical concerns that you are facing in your practice or that you are worried about because of the COVID-19 pandemic. The question that I first asked, do we have a professional and ethical or moral obligation to patients? Well, I think all of us would answer yes. To some degree, we do. We do have a moral and professional obligation to care for patients, even in the face of difficult circumstances. And I would argue that probably all of us who have practiced nursing have been in difficult circumstances, regardless of that practice setting, whether that was in an intensive care unit, a neonatal unit, a pediatric unit, in an operating room or an ER or some other type of practice setting. And some risk we accept to ourselves. And I underline "and some" because I want us to think about what is an acceptable risk to us during this time period. Generally, we think that indeed we have positive duties to help and to aid others who are ill and to alleviate suffering and pain. We also have specific role-related positive duties to provide care. We have a special obligation by virtue of our knowledge and our expertise. We have a social contract with society. We have a fiduciary relationship with our patients and their families, which is based on trust. And we know that we are trusted by the public. Every year, we are the profession that is most trusted by the public, and we are the largest profession. So we have expertise and skills that the public does not have. And therefore, we have an obligation to be able to help and support them. The ANA Code of Ethics, or the American Nurses Association Code of Ethics, outlines our values and beliefs as a discipline. And it sets the standards, as does the International Council of Nurses Code of Ethics for my global community friends and colleagues. And that was revised in 2012. But both of these guidelines speak to our fundamental responsibility to promote and restore health, to prevent illness, and to alleviate suffering. And these codes really embody who we are as a profession, and it guides us in our work. Now, it doesn't tell us specifically what we are to do in a pandemic, but it does provide normative statements about how we ought to act. And I think what I've highlighted here, if you see the two that I've highlighted, first of all, I think we would all agree that our primary commitment is to the patient, whether that's an individual, a family, a group, a community, or a population, and that we do practice with compassion and respect for the dignity, the worth, and the unique attributes of every person. But I think to some degree, when you look at the highlight of 5, the statement number 5, there is some conflict here, because how do we owe the same duties to ourselves as we do to others, but how do we maintain that balance by providing our commitment to the patient and caring for the patient, yet also worrying about ourselves and promoting our own health and safety and our own wholeness of character and moral integrity, and continuing our professional growth when we're facing some of the ethical challenges that I have outlined. And in speaking with Christine, I also think that the statement number 6 is very relevant to today, because we've seen so many nurses speaking out on the issues. So this statement about how we improve the ethical environment of the work setting and the conditions of employment that are conducive to safe, quality healthcare, I think is also important, and how we balance that. We do know there is some data that support an ethical environment, and that those who do not perceive that they work in an ethical environment are more likely to leave the profession. So how we balance all of these is very important as we move forward, and how we think about that with regards to the pandemic. Christine is now going to talk a little bit about pandemic dynamics and the standards of care and how we think about those ethical principles related to the standards of care during a crisis.
Thanks, Connie. I want to shift us just a little bit to try to recognize how pandemics do shift the way we think about acceptable standards of care. And I'm referring on this slide to some work that the National Academy of Science, Engineering, and Medicine has been doing for actually more than 10 years. They started to think about crisis standards of care in 2009 in response to the influenza scare. I think some of their work is very helpful because it helps us to think about the various ways that the standards of care might have to change in the setting of a public health emergency, including an infectious disease pandemic. And as you can see at the bottom of the slide, they've updated some of their work in response to the particular pandemic that we're living under right now. But I want to point out two things about this slide. Basically, during a crisis, it's vitally important to adhere to core ethical principles, and they name a few of them: fairness, duty to care, duty to steward resources, transparency in decision-making, consistency, proportionality, and accountability. And I'm going to define each of those a little bit better on the next slide. But before I do that, I want to point out another thing about this. They say, and I think this is right, medical decisions informed by these principles may allow for some actions that would be unacceptable under ordinary circumstances, such as not providing some patients with resources when other patients might derive greater benefit. And they go on to say that when resource scarcity reaches catastrophic levels, clinicians are ethically justified, in fact, ethically obligated, to use the available resources to sustain life and well-being to the extent possible. So the principles that they enunciated are on this slide, and I want to thank Denise Dudzinski for this slide that she shared with some of us in the ethics community, where she laid out the different principles that the National Academies had said were important in thinking about crisis standards of care. And they include fairness, that standards to the highest degree possible recognized as fair by those affected by them, including lots of communities who would be affected by the standards. The duty to care, that are standards focused on the duty of healthcare professionals to care for patients in need. We've already mentioned that, Connie did already, and we'll come back to it also later. The duty to steward resources, that healthcare institutions and public health officials have a duty to steward scarce resources, reflecting the goal of saving the most lives as possible. Transparency in decision-making and information sharing, consistency in the application of standards across populations and among individuals, regardless of their human condition. Proportionality in terms of public and individual requirements must be commensurate with the scale of the emergency and the degree of scarce resources. And accountability, in the end, we have to be accountable for all the decisions that we make. One of the things that I felt was very useful in the Academy's work is the description of a continuum of care for crisis standards of care. And this is important to me because I think we all have heard discussions or read in the news concerns about, maybe there won't be enough ventilators and somebody will have to be denied a ventilator. But in the preparation for crises of this nature, they distinguish three parts to the continuum of care for crisis standards of care. Conventional care, where everyday services are the way they normally are. We give the usual standard of care, we have the usual complement of patients or maybe a few more, but nothing dramatically has changed. Contingency care, when the demand for staff and equipment and pharmaceuticals begins to exceed this supply. And this, in the contingency care stage, we do everything possible to do functionally equivalent care, meaning that we try to give the care that we give in normal circumstances, recognizing that some adjustments are needed. And then crisis care, when the resources are so depleted that functionally equivalent care is no longer possible. One of the things that's really important for all of us to think about is how important the contingency stage is. And to my knowledge, despite the tragic circumstances that some cities in the United States are experiencing right now, very, very few places have entered the stage of crisis care. Most are functioning under contingency care kinds of standards. So another thing that's really important in this idea of how pandemics change the dynamics is that our ethical priorities shift. And this, again, I think to Denise for this slide. Our usual standards of care in usual circumstances are we prioritize respect for patient autonomy, maximizing the benefit to each of our patients, fidelity and allegiance to each patient. And we still know that in normal circumstances, not everybody who could receive benefit from treatment does get it, often because of lack of access or insurance. But when we shift to public health crisis or crisis standards of care, the focus changes from on the individual patients to taking into account respect for the common good. And that ends up having more weight in some cases than individual autonomy. It also is true that practitioners sometimes have less autonomy, that we are focusing on maximizing benefit to the greatest number of people and allocating scarce resources responsibly. And in this kind of frame, it's also true that not all who could benefit will receive the treatment they deserve, but it's due to scarcity rather than lack of insurance or lack of access. So one thing that's in addition to changing priorities, one thing that we should recognize is that there's a lot of fear, and Connie mentioned this before, but fear is not new. 5 years ago, Connie and I wrote a paper in the setting of the Ebola crisis and recognized that all of us who have worked in nursing and medical professions have been fearful at some point in our careers. Perhaps fear of communicating a poor prognosis to a cancer patient, or of placing an intravenous line in someone with scarred veins, or simply saying the wrong thing to a family in distress. We also sometimes fear for our own safety, such as when a violent patient lashes out, or a patient has active tuberculosis or another contagious disease. So these are not new situations. These are ones we've all experienced in one way or the other. However, at the moment, there are a number of unfamiliar challenges, and they range from things like military presence in our hospitals, setting up conditional hospitals that don't have the equipment that we're used to, but where we might be taking care of patients, starting a shift with prayers, realizing that patients and families can't see each other sometimes at all, or sometimes only between glass windows like this. Realizing that in some cases, the morgue is too full to accommodate all the bodies of people who have died. And also realizing that a lot of people are working very hard to make it possible to take care of patients, and they rely on other people staying home to keep them safe. So these are really unfamiliar challenges that we haven't seen or don't see very often in our nursing careers. So I want to say a little bit about dealing with scarcity of resources, because one aspect of the crisis standards of care and of the fear that we are experiencing has to do with the fact that resources are scarce. And these are a variety of different kinds of resources, as Connie alluded to earlier, including PPE, including staff, including beds, including ICU beds, etc. And Connie also mentioned that we are charged with trying to balance our care obligations and commitments with the duty to also care for ourselves and our loved ones. And there are two reasons that caring for ourselves is really important. And that is, of course, to protect ourselves and our families and the people that we come into contact with, both at work and outside of work. But also there's a utilitarian idea that we need to protect and conserve the healthcare workforce so that we can continue to care for people who are ill. And these become really challenging times across the continuum of care. So this is a busy slide, but I just want to recognize that there's a very interesting way to think about the continuum. As I mentioned before, there's usual standards, contingency standards, and crisis standards. And if you look at this slide, you'll see that the scarcity might be of stuff like medications, but also PPE and ventilators. The scarcity might be of space, and the scarcity might be of staff. And there should be, and there is, planning going on for what happens at the different stages of the continuum of care in terms of all of these elements. And you'll see if you look at the chart, I'm not going to read the whole chart, but I'll pull out a couple of items to draw your attention to. One is, in the usual operations, usual quality, there might still be reserve staff needed. But as you move along the continuum and get to crisis standards, things change with respect to staffing. And you may be in places where this is already happening, but many places around the United States and around the world are calling for staff who have been retired to come back into the workforce, staff who work part-time to work full-time. People are being shifted from one kind of setting where they usually work to another. I spoke to somebody the other day who's a pediatric critical care person, is now being asked to work in the adult critical care unit. And so these kinds of shifts have to occur as the crisis standards set in. But as I mentioned earlier, I think we are still in almost every place in the contingency stage of this continuum. I'm going to turn it now back to Connie to talk more about how we think about this balance or attending to our own safety and overall well-being, while we're fulfilling our obligations to care for patients.
Yes, thank you, Christine. This was one of the central questions that we were asking as to how do we think about our obligation to care for patients in this pandemic, especially when there is some uncertainty about the mode of transmission. I think we know that from the scientists that it is transmitted through coughing or sneezing or perhaps being in close contact with others through our breathing and talking. But I think there's still a lot that we really don't know about the mode of transmission, and I think we will certainly learn more in the days ahead. And there is concern, and we've seen this concern day after day about the lack of personal protective equipment that nurses and others who have had to use whatever they could find to protect themselves within the workplace. Staffing shortages that may compromise safety. We've had staffing shortages for a period of time. I know several of my colleagues at the University of Pennsylvania have done excellent work thinking about staffing shortages and what that might mean for patient outcomes. And so we are seeing these shortages. Again, I think as Christine said, many individuals are being called back to provide the care that is needed on the front lines. And what about when we have a loved one at home who might be immunocompromised, or we have a question mark here, it could be any other issue, maybe any other medical condition. How do we continue to provide care and be of service if we are fearful on many different fronts, or if we have anxiety, or if we're worried about many of these specific issues? Christine and I think as she said, we wrote a paper in 2015, and that paper was focused on Ebola at the time, and we were really worried about aggressive types of measures. So we were thinking about cardiopulmonary resuscitation for Ebola patients, but I think that this absolutely applies here with regards to COVID. And what we said in that particular article is that, yes, indeed, we know we have professional obligations to care for patients, and we know that we face difficult circumstances and some risk, but it's not absolute. There is not an absolute duty when we face risk. And if there is risk to the nurse, sometimes that can be a justification for not providing particular kinds of care in certain circumstances, and it can outweigh the nurse's obligations to provide care. It might not make us feel good, but there is certainly not an absolute duty. So in the face of possible serious or life-threatening risks to the nurse, there has to be a careful balance or a careful analysis of these risks in light of possible benefits to the patient, and that is crucial. I know that several of my colleagues, Dr. Halpern at the University of Pennsylvania, has been thinking about these issues, and particularly related to cardiopulmonary resuscitation for COVID-19 patients, and trying to identify the guidelines that might be used within a particular ICU, and whether or not the possibility, for example, that cardiopulmonary resuscitation might not offer benefit, to that particular patient, given that they might have comorbid conditions, and the probability that performing cardiopulmonary resuscitation will just increase the transmission, threatening the health and welfare, and reducing the ability of healthcare providers to treat future patients. I know that many people are thinking about these particular issues and the risks that we might face with regards to this pandemic. The American Nurses Association has a position statement on risk and responsibility in providing nursing care, and this it was developed in 2015. And Christine and I have used this as a guide for thinking about whether or not we have an absolute duty to provide care. And if all four of these criterion are met, then yes, we might say that we have a moral obligation, and they include the responsibility if the patient is at significant risk of harm, loss, or damage if the nurse does not assist. The nurse's intervention or care is directly relevant to preventing harm. The nurse's care will probably prevent harm, loss, or damage to the patient. And then finally, the benefit the patient will gain outweighs any harm the nurse might incur and does not present more than an acceptable risk to the nurse. And I think this last statement is the one for me, and I think for all of us to be thinking about with regards to what is that benefit to the patient, and what is the benefit that that patient will gain, and does that outweigh any harm that the nurse might incur with regards to whatever type of procedure or treatment that we might be indicating for that particular patient. So yes, indeed, nurses and other healthcare professionals promise to provide care to those in need. Our skills are not transferable. Healthcare providers cannot be easily replaced. We are very unique because we do have that appropriate training, as I talked about. And yes, indeed, healthcare workers voluntarily assume some risk, knowing that they will need to help in emergencies and pandemics, and they are courageous in many ways. But healthcare organizations also have a reciprocal duty to protect healthcare providers, and I would also argue that they have a moral duty in some respects to keep their employees safe to the best of their ability. So what I would really like you to know is that ethically, nurses and other healthcare providers can decline to do certain things when the risk to the healthcare provider is too great. It might not make us feel good, and there might be some retaliation or reprisal or retribution, but ethically we can speak out if we feel as though the risk is too great. And Christine is going to talk here about the ethical values and guiding principles of rationing when we do have scarce healthcare resources.
Yeah, so this is a chart that came out of an article that was in the New England Journal of Medicine about a week or 10 days ago now. Emmanuel and Prasad and others who are the authors. And what I like about it is it lists the ethical values and guiding principles that are fairly commonly accepted in allocation of scarce resources and rationing decisions, and then tries to apply them to the COVID situation. Importantly, there are some of these values and guiding principles that are widely accepted as relevant, and there are others that are a little more controversial. So I'll try to just point them out very quickly. The first one I think is most people say that in the setting of a pandemic, or when allocating resources and scarce resources in any situation, the most important thing is to maximize benefits, and to do so by saving the most lives, and that receives the highest priority. I've had people say that what we really should think about is that in maximizing benefits, the most important thing is providing the best care for the most people, but doing so in a way that sustains trust in the healthcare system and some social cohesion. Some of the other values that are listed on this slide really are a little more controversial. So the second one is treat people equally. And in this situation, at least these authors argue, first come, first served doesn't work. but random selection should work. And a lot of people have debated how you would actually do that. And then the third thing that they look at, promoting and rewarding instrumental value, is also controversial. I think the first one, though, maximizing benefits, is what most people agree on. What's interesting about this is that in the setting of COVID, many states around the United States and even other countries, including Italy, have published allocation frameworks that employ some of these ethical values and guiding principles, but give very specific guidance to healthcare institutions for how to make those very difficult decisions that might have to be made in crisis conditions. And one of the things that many of them do is describe what would happen in crisis conditions. There would be a criteria for triage, but also many of the guidelines that do exist suggest that there should be triage teams. And the reason for this is that it takes the burden of making those very difficult decisions away from the frontline providers with respect to their own patients, and puts them in the hands of somebody or a team that knows how to put the criteria together, but doesn't have the same investment in those patients and doesn't know the sort of details of those patients except for their medical details. Most of the guidelines suggest that a triage team should be created. Some say a triage officer. And the ones that suggest a triage teams almost invariably include 3 people, a medical officer, a critical care nurse, and often an ethicist as the third. It is true that this is one of the hardest decisions that healthcare workers are going to have to make. I think another thing about this is that it doesn't mean, if decisions have to be made where a particular patient is not able to get a certain kind of resource because of the scarcity, it doesn't mean that that person doesn't deserve it. It means that they can't, that there just aren't enough for the number of people there. And so the decisions are being made on maximizing benefit, who has the best long-term or short-term survival. At the same time, patients who do not receive certain limited resources should still always receive quality care and palliative care as appropriate. And we, as nurses and other healthcare providers, will continue to care about all of the patients, not just those who get the coveted resource. When we're thinking about this shift, as we talked about before, from the idea of caring for individuals to shifting to thinking about the needs of the community or the population, and having to perhaps make very difficult decisions about allocation of scarce resources, this shift, and I'm going to point to the last box on this slide, creates great tension for clinicians, including ethics consultants, and that's what my job is, but for clinicians who are on the front line, for clinicians who are making the decisions, and for everybody who's supporting them. And this makes me want to remind us that there's a potential for some considerable moral distress here. As many of you know, many clinicians, many nurses and other healthcare providers experience distress and moral distress in their normal, usual care conditions, under usual care conditions. But in this kind of situation, moral distress, or the feeling of being unable to do the right thing, or feeling powerless to avoid wrongdoing or harm, or perceived wrongdoing or harm, is foreseeable during a prolonged public health emergency, and especially when resources are limited. So I think it's probably important for us to recognize that moral distress is likely both before, during, and after crisis conditions might attain, and we should recognize that that's the case and do whatever we can to address moral distress. I think it's also true that we all see, and I'm sure some of you are examples of this, We see nurses and others being very courageous, doing what they need to do to care for the patients that they have. We've read things like nurses wearing garbage bags because they can't get the equipment that they need for gowns, making makeshift shields and masks, and doing other kinds of things to improvise in order to be able to still care for their patients. And one of the things that Connie and I have thought about a lot and tried to do some work on and have more work to do on is what we're calling moral strength. And it always strikes me as remarkable to think about what is it that gives nurses and others the moral strength to continue to practice in very difficult circumstances. We think of moral strength as the capacity of clinicians to practice with confidence, with moral clarity, and with compassion, and to make difficult ethical and clinical decisions within complex environments. It's the kind of steadiness, stability, and focus that I've seen in many people that I work with that resides in and supports those who care for patients day after day, year after year, and engage with the moral complexities. Yet in crisis conditions, in crisis situations, even the very strong healthcare workers and nurses are going to have to live with decisions that they really didn't want to see happen. And that's even if they agree with how the decisions were made. So we need to do everything we can to support and promote moral strength. And I think that includes preparing for the possibility of crisis conditions, being clear about our roles and our limitations, teamwork and communication, and using available resources, palliative care, ethics consultation, and other spiritual care and others, and also taking care of ourselves, taking breaks, sleeping, getting exercise, all the things that we really need to do when we're working in difficult conditions. I liked this quote from FDR that says, "Courage is not the absence of fear, but rather the assessment that something else is more important than fear." And I think that, to me, exemplifies the sort of everyday heroism of healthcare workers that are working under very difficult conditions to be able to take care of their patients and trying to balance care for themselves as well. I want to end with suggesting that this cartoon, if you will, shows that, COVID can be beaten, and healthcare workers are an important part of making this happen, as is research and other kinds of things that are ongoing with great urgency. And I think I want to recognize that all of you who work on the front lines really deserve a lot of gratitude and appreciation for all that you do. And I think that's our last slide. Oh no, references. References in case you want them.
Okay, we have
now we are available to discuss or answer questions.
perfect. We have several questions coming in.
Good.
Is it wrong for a nurse to refuse to care for a patient when the nurse does not have personal protective equipment to work with?
So I can start there, and then maybe Connie can
Yeah.
jump in and say what she thinks.
Yeah.
I think under certain conditions, the answer is no, it's not wrong.
Right.
But it depends on the conditions. And what I mean by that is not every activity, not every action that a nurse takes has the same degree of risk. And not every situation has the same lack of personal protective equipment. So there are situations where nurses are working without personal protective equipment in settings where the likelihood of coming across somebody with COVID is very low, and that's probably okay. And they may be working with masks like some of us are wearing to the grocery store. In other settings, in ICUs, for example, nurses need serious personal protective equipment, N95 masks, goggles, other things like that in order to protect themselves. And if they don't have those, I think there are some things that they can refuse ethically to do.
I agree with you, Christine, and I agree. My answer to this question is also no, it is not wrong. But I think that sometimes we feel it's wrong personally, because when we go back to thinking about, our primary commitment, we're trained, right, to take care of patients and to do the very best we can to meet that commitment. But I think that's the conflict that we often feel, is that indeed we also have an obligation to care for ourselves. And there has to be some responsibility with regards to healthcare systems and settings for those of us who are working within those systems and settings, that they are providing the necessary resources that we need, not only to protect ourselves, but to protect our patients. So I think it is a fine balance many times between thinking about the benefits and the benefits and the risks to the patient, but the benefits and the risks also to myself. So I would say no, it is not wrong from an ethical perspective.
What are the legal stances on contingency and crisis care? When we stray from usual standards of care in cases of a pandemic, in cases of a pandemic like COVID-19, and patients' lives are compromised, does the law stand with us?
Hmm.
That's a great question.
Yeah.
And as I understand it, most states in the United States anyway, once a governor rules that a state is under a state of emergency, then the crisis standards are adopted, then there is protection from legal liability for the healthcare providers that are providing those services.
And
I
I
don't
think we
know what the situation is legally in other countries, but I know that some of these same allocation frameworks were put into place, for example, in Italy, and I think with legal protection of the providers as well.
And I think we've seen that too, Christine, with regards to licensure. So crossing state lines, for example, going from Maryland to New York City, if I wanted to do that with regards to my license, I would be protected to be able to do that legally because of the pandemic and the crisis.
If the risk is too great, then the nurse can refuse to put him or herself at risk. Is this purely defined by the nurse's level of risk? What voices are important to determine risk to the nurse?
So if you go back to that, I don't know if you have that slide, the four criteria that the ANA put out, I think are really helpful.
Yeah.
Because what they do is they give you criteria by which to evaluate the risk and the possible harm to the nurse as well. This one, yeah. So in a particular situation, if the patient is at significant risk of harm, loss, or damage, if the nurse does not do what he or she is supposed to do, the intervention that the nurse could provide is directly relevant to preventing harm. The nurse's care will probably prevent harm, loss, or damage to the patient, and the benefit that the patient will gain outweighs the harm the nurse might incur. So that's a sort of standard risk-benefit analysis. And so the answer to your question is it really depends on what the intervention is, what the situation is with respect to protective equipment, and how much risk the nurse feels he or she is under.
And I think we have to be able to communicate that risk, that we feel that it is a risk. So, I think Christine talked a little bit about teamwork. How do we work together as a team? How do we be transparent with what we're feeling? And that potentially we might feel that we are at risk if we do not certainly have the personal protective equipment. And how do we speak to our managers or healthcare administrators about these particular issues so that we can feel more comfortable in placing ourselves in these situations?
How do you tell patients not receiving those limited services that they can't receive it, and do you tell them why?
Yeah, that's a great question.
Mm-hmm.
So there have been huge discussions about this among the ethics community, and there are a couple of things that I would say. One is most people recommend that there be great transparency when these guidelines are developed in a particular region and when they're put into place. So that, in other words, people in the community around the hospital know that this is happening. Some have argued that we should be telling people when they get to the hospital. If we're in crisis standards of care, this is the situation. Others say that doesn't make sense and we should just tell people at the time that those decisions are being made. I think it's, as the questioner, I'm sure, thought of when he or she asked the question, those conversations must be really difficult to have, but I think having them is necessary if those decisions are being made.
Thank you for the terrific presentation on ethical considerations in crisis, a topic that is often overlooked and understudied. Would you care to comment on the ethical issues in our current situation in which global country leaders are considering both the economic concerns over closing down businesses in their countries and the real-world economic issues and public health concerns? Many countries do not have the financial reserves like the U.S. and are in financial crisis situation due to stopping commerce in their country and the need to adhere to public health data and recommendations.
Yeah. So it's a really tough,
Yeah.
my own views, really tough balance because economic crises can also affect health in the end, and not just not just the economy. In a sort of crude way, it's a calculus of how much risk you're willing to take. How many deaths are you willing to accept in a situation where there's tons of uncertainty about where this virus is going and how many people will ultimately be infected. So it's a very difficult calculus. I don't have a good answer for any of those.
Let me just also say that, I mean, I agree with Christine on this. It's very difficult, and there are many financial issues that we see them here in the United States as well. There will be access to care issues. There will be insurance issues, financial ruin for some people, I believe, in the future. Also globally, I do work in Tanzania in Africa, and I have been trying to have some email conversations with my colleagues there. I know that they do have cases, for example, in Tanzania, and they are starting to try to think about these particular issues, not necessarily from an economic perspective, although I'm sure that will come because resources are limited. And when we even think about the number of nurses or physicians that they have, they are limited with regards to that too. But I do know that they are starting to think about these particular issues, even though they have a smaller case number than we have here and throughout other global communities, about what this might mean for them. But I don't think they're at that point yet. But I know that will come in the future.
I know caring for families of the patients may not be at the forefront during crisis. However, I can't help but think of the long-term effects like PTS, post-traumatic stress, and complicated grief the survivors will live with. What do we owe families?
Yeah, this is very, very difficult as well. And I thank you for this question. I just recently published an op-ed in the Boston Globe about this concern because I'm very concerned, about the emotion, the short-term and the long-term emotional well-being of nurses and families and patients and others. And I absolutely agree with this particular caller here that I am worried about PTSD, about depression, about cumulative grief because nurses, for example, are seeing loss after loss of patients. I mean, we're used to seeing loss, but not at this volume. And with regards to patients and families, I think being isolated from your loved one, going into the hospital, having to be isolated, going to an ICU, for example, at the end of your life, not being able to communicate perhaps with a family member. These are all issues that for family members are going to be able to be quite distressing and even morally distressing, for them. And I think in the long term, we're going to have to think about what resources are going to be needed for families, for clinicians, for everyone who's associated, with this particular situation, because I do believe that emotionally long term, there is going to be a significant burden.
I think in the short term, too, there might be some things that we can do to help families. I think as Connie mentioned, unfortunately, because of visiting policies and fear of contagion, sometimes when somebody is really sick, their family cannot visit them. They can't see them. But people are being creative with, devices and other things where they can talk to each other, write to each other, things like that. I think it's also a time that we call in the resources that are available to us that sometimes are pretty stretched already, but palliative care services, spiritual care services, maybe volunteers who live in the community who can help with families who are struggling. I think there are some examples of this that are happening in some places that I think are quite heartening. But to the questioner's point, the stress and the sadness and the isolation on families is going to be great.
I did read something a few weeks ago, I believe it was about palliative care support, a palliative consult where the palliative care individual was actually coming to the emergency room. And if the patient was having such difficulties where they most likely were going to be going to the ICU and on a ventilator, they started to have those kinds of conversations about palliative care and with the family about what they particularly would want in this instance. Now, that might not be the best, at that moment, but at least I think we need to begin to have these kinds of conversations to help families in the long term, short and long term.
Nurses are being asked to mention and start speaking to patients regarding advance directives. What is the best approach for nurses to take and the best timing to speak with patients and families, especially since families aren't at the bedside?
Yeah.
Yeah.
Great question. We should be talking about advance directives with people,
right now.
last year.
Yeah. Right now.
Something that we should be talking to people about all the time. But I think really importantly at this point in time, giving patients who can make decisions the opportunity to express what they want at the end of life is really, really important, because there are some people, I've seen examples of this, and maybe many of you as well have, who rather than taking up the ICU bed would rather stay at home and let somebody else have that ICU bed.
Mm-hmm.
And for people who want to make that decision, we should give them that opportunity. I think for those people who've never thought about this before and have never had an advance directive, if they're coming to the hospital already in extremis, it's going to be very difficult to have that conversation at that point.
Yeah, I agree. I mean, I think, we know the data, about a third of Americans, for example, have an advance directive. So we know that we've struggled with trying to have these conversations. We don't always feel confident having them, but I do think that now is the time, even within our own families, that we need to have these conversations before we might ourselves, be in the hospital. So I think, as Christine said, we should have had them a long time ago, but perhaps now with COVID, it really has brought it to the forefront that we need to begin to have these kinds of conversations. And they are sensitive, but they are so important, to determine what is it that we want and what is meaningful to us.
Healthcare professionals such as physicians, nurses, and RTs are licensed to practice with a certain legal authority. Are you concerned that physicians and nurses are being asked to practice beyond their scope of practice during this pandemic?
I think that they're being asked to sometimes provide care out of their comfort zone.
Yeah.
I think so. What I mentioned before, somebody who's a critical care practitioner who now may need to work with adults instead of children, their scope of practice still might allow that, but they're not used to working with adults, and there are certain things that they'll have to learn. I think that many of us will have to do things that we are not comfortable with, but we should be careful about going too far outside of our scope of practice, because that, defeats the purpose.
Do you recommend for a nurse to have malpractice insurance in case of any medical errors they may occur due to stress and fatigue?
That's a great question. I'm not sure how to answer that question.
Maybe somebody could tell us, how often do nurses have malpractice insurance anyway? Is that a common thing?
I assume that you were most likely covered by your hospital system.
Organization, yeah, okay.
Yeah. but that certainly might not be the case with every institution.
Yeah, sorry, we don't have a good answer on that one.
But we definitely will try to find the answer for you. But I hear what you're saying, actually. I mean, I do agree with you in the sense that you're right. I mean, some of the literature and the data do show that, individuals who are tired, who are fatigued, who are worn out, there is a higher possibility there that you might have a medical error. And I think that, that is worrisome on many different levels. But I certainly don't have the answer with regards to the legal issue here, but we will certainly see if we can find out what that might mean.
What resources do you recommend for nurses dealing with moral distress?
Well, I think there's some literature that suggests that there's a few things that do help in normal circumstances, and I can't imagine that they wouldn't also help in these circumstances. And those include things like working with a team, being able to express one's views about what is happening or not happening, having transparency from the institution about what the rules are, what the expectations are, what the limitations are, having respect between members of the team in terms of respecting collaborations. I mean, all the contributions of the collaborators and things like that. There are also some hospitals that have moral distress teams, often through the ethics consult service, that go out and sort of help groups of people when they're in specific situations of distress. So calling on those kinds of resources to the extent that they exist. I don't know, what else, Connie?
Using your voice, making sure that you are being proactive, using your voice to express any concerns that you might have, seeking ethics consultation service. You might not have a moral distress service. I know UVA does, University of Virginia does, but you might not necessarily have that at your university or but you can consult with an ethics consultation team that is at most hospitals if you are suffering from moral distress or have a concern that you need to discuss with a particular objective voice, so to speak, and or palliative care. You can also call a palliative care consultation if you need to speak with someone, and pastoral support. Absolutely, you can contact them as well.
How do we navigate the ethics for nursing and do what is right by our own oath when we see the political climates around the globe that are using the pandemic for political gains or to try to spin a story?
Yeah. Politics gets in the way of a lot of things. I think having some clarity about what our role is and staying focused is probably the right thing to do, despite the political spins that are happening out there.
How do we advocate? Oops, sorry.
I'm sorry. I just want to say that also that I think, there is concern about trust and mistrust with regards to the system, the larger political system, the healthcare organizational systems. Who can we trust to tell us the truth when every day there are changes with regards to what we need to do to protect ourselves or to protect our patients. And I do think that we have to continue, as I said before, to use our voices in whatever possible way that we can do that. I was saying to Christine earlier before we began, I do think that perhaps now, I've always worried in the past about whether or not the public actually saw the value of nurses. But I think now, with this COVID-19, that the public does understand the value of having a nurse, someone that is skilled, that has the expertise and the knowledge that can provide that critical care for that patient or the family, their loved one, when it is needed. So I would argue that let's just continue to use our voice. Let's continue to look at the literature and the data that help support guidelines or other practices that are needed, and try to get the best information that we can.
I cared for a patient in Sierra Leone during the last epidemic. Upon my return to the U.S., I experienced psychological trauma. What measures could nurses take to avoid experiencing psychological trauma?
I guess the question is, was the psychological trauma from the experience of caring for patients in that setting, or from the reaction of people when you came back to the United States, or both? You think, caring for people in a setting like what happened in Sierra Leone a few years ago has to be traumatic in many ways. And I presume that despite that, you volunteered to go there and do that with whatever organization it was with. I don't know how to.
I think there are also, there are resources available. I know the National Academy of Medicine on their website has a resource for clinician well-being. There is much worry about clinician well-being, such as you have indicated with regards to psychological trauma, and resources that we can use as clinicians to help ourselves. And there are also resources on the I believe it's the American Psychological Association for Nursing. They also have a site that gives us some techniques that we can use with regards to the trauma that we might be experiencing. And I think, as Christine said earlier, sort of self-care techniques. What can we do to take care of ourselves? And that they might seem simplistic, but we need to do them. We need to eat. We need to take breaks. We need to sleep. We need to communicate with our loved ones. We need to communicate with our colleagues and our peers about what we're feeling. We need to debrief, about what we've seen, to help relieve some of that trauma. But there are many mental health resources out there that we can give you a link to that might help you as well.
I think also I work at the National Institutes of Health. The NIMH, which is mental health, has been putting together some resources for healthcare providers. And I don't know if they're already online, but we'll find the link and get that out as well.
I think they are, Christine, online. Yeah.
How do we advocate for additional resources for our hospital, for our city, or for our community?
I think you start by advocating at your hospital level. Collective action, that sixth principle or whatever it is on the ANA Code of Ethics, that
the ethical climate. Mm-hmm.
It's, there is some responsibility for nurses and other healthcare professionals to, care about the environments in which they work and take action, even if it's collective action, to try to get the resources that are needed to have safe and quality care.
There are institutions.
Can I just say
Yes.
one other thing too?
Yep.
Is that thank you for your question. Yes, you certainly can advocate on many different levels. But I also want you to know that Christine and I also are advocating on your behalf. We are trying to do that by getting the message out, by writing, by putting things out there, recognizing that nurses are in need of many things during this COVID crisis. And so we are also here as a resource to try to advocate on your behalf if you cannot do so. But you certainly have every right to voice your opinion, as I said earlier on that slide, based on the ANA Code of Ethics, as Christine said, that one statement about, how do we produce a better quality, an ethical environment and quality within our work setting. So we have every right to voice our concerns to improve that work setting, because it not only improves how we might feel working within that institution and supporting the mission of that particular institution, but ultimately it benefits patients and their families. And that's the ultimate goal here.
There are institutions that prohibit nurses from bringing in their own supply of PPE when the supply is low. Any advice on how to address this kind of situation?
And I assume they're worried that the PPE that's being brought in is not sort of adequate for the circumstances. But if they're not providing the PPE that you need, then I think it's a sort of, not battle, but a debate that you need to have with the powers that be that are making those decisions. Because I know, for example, in the hospital that I work in, they are very, very, very carefully stewarding the supply of N95 masks and making sure that only people in on units and in situations where they need them, have them. Nobody else needs them. None of the rest of us in the hospital need those masks, but we have regular surgical masks. And so I think, being clear about what you need in certain circumstances and then negotiating with the leaders of your institution to get those in those circumstances so that you don't have to bring in your own from home.
Well, thank you so much to our presenters today for the great information. Sigma is grateful that you took the time to share with this audience and look forward to hearing from you in the future. Just a reminder to our attendees, please submit the state or country you are from. And thank you to our attendees for joining us. Have a wonderful night.
And
Thank
if
you
anyone,
all very much.
yes, thank you all very much. We appreciate this opportunity and the time to talk with you.
And we appreciated your questions. They were great.
Yes, very good.